Welcome everyone to our third and final webinar in the three-part series on fall risk screening and assessment. At the first two webinars in this series, we talked about fall risk screening and then assessment. And the focus of today's webinar is indicators, implementation, and evaluation. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman, and I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. And Parachute now sponsors the Fall Prevention Communities of Practice Loop and Loop Junior, along with the annual Fall Prevention Month campaign. So before we get started, I want to start today with a land acknowledgement. So today we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and the unceded territory of the Indigenous peoples, Canada's First Nation, Inuit and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I want to ask that everyone take a moment to themselves to acknowledge the land where they currently reside. Next, I just want to cover a few housekeeping items. During the webinar, if you do have any questions about the technology, please type them into the chat box and my colleague Elaine will be monitoring this. If you do have any questions for our presenters about the webinar, you can submit those through the Q&A box. They will be answered at the end of the webinar. And you'll only be able to view questions you have asked and not questions posed by other participants. The webinar is being recorded and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. And you can view previous webinar recordings. Simply head over to the webinar page on Loop and click on the archive webinar page. And you can also watch it on our YouTube page. I'd like to now introduce our presenters. Dr. Sarah Richmond, epidemiologist at Public Health Ontario, and Denise Beaton, senior policy analyst at the BC Ministry of Health and a member of the BC Injury Research and Prevention Unit. For a complete bio on our presenters, please take a look at the Loop event calendar. And you can also watch the previous webinars in this series at our YouTube channel or on Loop, and that's where you can also access the slides from those presentations. So without further ado, please take it away, Sarah. I'll let you share your screen now.
Thank you. Can you see that?
Yep, and just seeing the slide. Looks good.
Thank you. I just wanted to note, I'm just going to go off camera for the duration of the presentation just to limit the number of technical issues that I may experience during this presentation, but we'll be sure to turn my camera on after my presentation. So a huge thank you to everyone tuning in today and to Parachute for inviting me to present on this work. Again, my name is Sarah Richmond. I'm the Injury Prevention Lead at Public Health Ontario, as well as an assistant professor at the Donnellana School of Public Health at the University of Toronto. I'm really happy to bring you this work. It's a bit of a result of a couple of years of work on the prioritization of older adult fall prevention indicators in Ontario. Sorry, there we go. I'd like to acknowledge the co-authors of this work, Dr. Alison McPherson and Dr. Ian Pike, as well as the students and my epidemiologist from Public Health Ontario, Alexia Medeiros, our students Subhana Shabazz and Alison Andrews-Paul, who without them, this work would have not come together. So a big thank you to them. I'd really like to thank the Ontario Fall Prevention Collaborative as a very significant collaborator and stakeholder in this work. So just a really quick review of the agenda for this presentation. I'll start with a bit of background and rationale for this work, dive into the methods that were specific to prioritizing the indicators for this work, the results, and then sort of finish this presentation talking about a few of the strengths and limitations to this work, and invite some discussion on the results as well as the implications for practice. I'd like to finish the presentation by introducing some of the future work in this area. So a bit of background. Of course, why we are all here and attending this webinar today is that falls are a frequent experience for older adults in Canada. It's estimated that approximately 20 to 30% of older adults fall every year. Falls have immediate physical consequences, including injuries, and represent the leading cause of injury-related emergency department visits and hospital admissions among older adults in Canada. We know from the most recent publication of the cost of injury report published by Parachute and the BCIRPU that fall-related injuries represent the highest cost of all injuries to Canadians at $10.3 billion in direct and indirect healthcare costs. Falls in Ontario are high. In 2020, there were over 45,000 ED visits and 7,000 hospitalizations due to falls in older adults ages 65 to 74 years. As you can see here from these data over time, from 2011 to 2020, the rate of injuries due to falls is not decreasing. Despite what looks like a dip in the rate of ED visits and hospitalizations in 2020, there was still a rate of over 3,000 ED visits per 100,000 population in 2020, as well as approximately 500 hospitalizations per 100,000 population. Fall prevention initiatives have shown effectiveness at reducing healthcare costs associated with falls. However, there is a disconnected approach across sectors in Ontario that can hamper our understanding of the impact of fall prevention efforts. The Ontario Fall Prevention Collaborative was established in 2019 to facilitate a system-wide approach to fall prevention in Ontario. This group emphasized the need for population level as well as programmatic indicators, both for surveillance and to inform implementation and evaluation of interventions. Therefore, the objectives of this project were to develop a list of existing indicators and those currently in use in fall prevention practice across sectors in Ontario, to prioritize these indicators for use in the province across sectors, not by sector, and develop specification tables for each prioritized indicator, and then eventually to populate a set of indicators and to evaluate their use in practice. So how did we do this work? This is a bit of a busy slide, but it is to describe sort of at an overview level the process of completing this project across two phases over a couple of years. The first phase included a peer-reviewed and gray literature search, as well as engagement with our stakeholders to understand the indicators currently in use in Ontario. Our second phase included an online survey, a prioritization process, and consultation with injury indicator experts. This process concluded with a final list of prioritized indicators with indicator specification tables that can provide guidance, some technical guidance on the indicator's use in practice. So just a little bit more about the methods by phase. So in the first phase, which we're considering the literature review, the approach to developing the list of indicators is previously published in a report supported by the former Ontario Neurotrauma Foundation. However, in short, indicators were identified from the literature using relevant vocabulary and keywords. Information on each indicator was extracted from each data source, including the source document, the geographic location and year, as well as the type of indicator reported. For example, what was a policy level indicator or an outcome indicator, as well as any data sources used to populate the indicator. Finally, each stakeholder from the Ontario Fall Prevention Collaborative was asked to populate a list of currently used indicators from their sector. And they were also asked to populate each indicator using specifying the data sources that they would use to do this work. The literature review reported a very long list of indicators. You can see a small excerpt here from Public Health. And this previous report, titled An Environmental Scan of Older Adult Fall Prevention Indicators, lists all of the indicators from the literature review by sector. The sectors included were public health, pre-hospital care, hospital care, rehab care, home and community care, as well as long-term care. That report is accessible online, again, published by the former Ontario Neurotrauma Foundation in consultation with the Ontario Fall Prevention Collaborative. More information on the method specific to the environmental scan and literature review is available in that report. The second phase included an online survey. The survey was administered to stakeholders from the collaborative, asking them to score each indicator from the list provided from the environmental scan on a scale of 1 to 9. This was from do not agree to extremely agree based on 3 criteria: usefulness, feasibility, and the ability to prompt action. These criteria reflect the critical functions of indicator collection and reporting and were chosen based on expert consultation, as well as previous work published in this area. Scores for each indicator and criteria were summed and averaged, and those scores were used to determine a total score for each indicator across the 3 criteria and across sectors. The list developed from the online survey was then further refined in a consultation process with our team of experts. Phase 2 also included a prioritization process. We hired a third-party focus group consultant to conduct a prioritization activity with key stakeholders from the collaborative. We recruited a sample of stakeholders for this activity that included at least 1 stakeholder from each sector. In preparation for this activity, we provided the stakeholders with resources, including the list of indicators previously refined from the online survey. Participants in this activity spent about 60 minutes discussing each indicator and completing a pairwise ranking exercise. Each indicator was compared to each other on which was a priority based on one of the 3 previously used criteria. And in this case, we chose the ability to prompt action for fall prevention in Ontario. This was chosen again based on expert consultation and previous work that's published in this area. Scores were recorded for each comparison, giving 1 point for each pair 1, with a total of 136 comparisons made during the prioritization exercise. During this exercise, we advised stakeholders to think about which indicators should be prioritized across sectors over what is considered a priority within their sector. In addition, we asked stakeholders to consider the 1 criteria, the ability to prompt action, in their prioritization process. We collected final thoughts and feedback on the list that was produced by this exercise and invited all of the stakeholders' thoughts and feedback on the ranking list. As I mentioned previously, we prepared indicator specification tables as part of this phase as well. We collected information on what should be included in the specification tables and how that information should be organized. Information within the tables included an operational definition, relevant key terms, methods and data sources used to calculate the indicator, where the data can be found, and potential subcategories and ways to stratify the indicator, as well as any existing limitations. The information detailed in the spec tables was adapted from the Measuring Injury Matters report published by Pike et al., as well as the Association of Public Health Epidemiologists of Ontario, or the AFEO Core Indicators Table, as well as the Public Health Ontario's Injury Snapshot Technical Notes. So some results from this project. These are the results of the prioritized list of indicators across sectors and the 3 criteria from the online survey. So just a reminder, the criteria were usefulness, feasibility, and the ability to prompt action. So you will see here the 9 prioritized indicators where the rate of hospitalizations due to a fall and the rate of ED visits due to a fall were prioritized at the top. And disability adjusted life years due to a fall, as well as the number of 911 calls transported v. not transported, were the least prioritized. This is the list that was refined from that online survey and the result of the prioritization process using the pairwise comparison exercise. So as you can see here, the rate of ED visits ranked highest on this list, as well as second to direct and indirect costs associated with fall-related injuries. The rate of mortality due to a fall, as well as the proportion of falls by place of occurrence, ranked the lowest. You can see here that the proportion of older adults with a comprehensive falls risk screening and assessment completed retained its position as fourth highest in priority. The indicator specification tables provide information on the importance and use of each indicator, as well as how data should be interpreted and used in practice. We provide operational definitions as well as key terms included in the indicator title or its description. We've also included a section on how the indicator is calculated, so the numerator, the denominator needed, as well as the sources of data required regardless of data availability in Ontario or in Canada. Where available, links to data sources or existing documents that report on these indicators were also included. There are several strengths to this work. The first is in its novelty to Ontario. This is the first time that a prioritized and specified list of indicators will be made available to fall practitioners in Ontario. This can facilitate the systematic use of indicators for reporting and program implementation and evaluation across the province. Our methods were informed by experts using previously published methods, and those specifically in use for older adult fall prevention from the University of British Columbia, as well as the BC CDC. An additional strength includes the iterative engagement of stakeholders across the process. Our results were revised based on stakeholder feedback, and we really tried to put a lot of effort into consulting with experts and practitioner representatives across sectors in Ontario. There are, however, some limitations to this work. The literature review included only sources published in English. Therefore, some relevant non-English sources may have been excluded. Second, the survey results were limited by low participation rates. This was due to what we suppose is a redeployment of many fall practitioners in Ontario to the COVID-19 response. Third, the consultation process to prioritize indicators in the first round demonstrated a bit of a disproportionate contribution in the discussion. So certain sectors were more vocal than other sectors in the initial prioritization exercise. As a result, we implemented the pairwise comparison activity to limit this, to sort of mitigate this limitation, pardon me. As a result, we allowed equal participation from participants. We had equal weight placed on each stakeholder's response during this activity. 3 of the prioritized indicators do not have data accessible in Ontario. And finally, there is a lack of a gold standard set of indicators for older adult fall prevention. A gold standard set of indicators could be used to validate the performance of these prioritized indicators in practice. So, discussion and conclusions. This project demonstrated clear differences in setting priorities for fall prevention indicators across sectors. For example, stakeholders expressed that certain indicators were more or less of a priority as you moved across the continuum of fall prevention. For certain sectors, risk screening and assessment was a prioritized indicators and not for other sectors. This indicator, however, garnered a lot of conversation in our stakeholder and expert consultation process. It was discussed that it is one that's difficult to use potentially in practice. As we know, fall risk screening and assessment are informed by clinical practice guidelines. However, it's difficult to ascertain if CPGs are used in Ontario, how they are used, and by whom. This was a really important consideration when thinking about this as an indicator itself, as without existing CPGs that are used systematically across Ontario, this indicator may be less useful for practitioners to action. One of the most significant actions from the consultation process was to refine the list of indicators from the literature search to the prioritization activity. So for example, here, several indicators were derivatives of what we considered higher order indicators. So for example, the rate of emergency department visits was considered an indicator, as well as the rate of emergency department visits due to falls across levels of marginalization. So we had to do a lot of work along the process to refine indicators and sort of collect indicators at a higher level and state where there could be disaggregation of that indicator and not that it was a completely separate indicator on its own. Another example from our discussion included the length of stay in hospital for fall-related injury. And this was, again, considered a subcategory, or the ability to disaggregate this information from the rate of hospitalizations due to a fall. Interestingly, expert opinion noted that this indicator is often considered by researchers and practitioners as a proxy measure to injury severity. However, length of stay, particularly in older adults, may be confounded by existing comorbidities. Finally, another subcategory of the rate of hospitalizations was the number of femur, hip, pelvic, and vertebral fractures. This was considered very important information from our stakeholders. And we know that previous literature demonstrates that these fractures are a strong predictor of lifelong disability and even death. Finally, the proportion of injuries by place of occurrence was the indicator currently ranked as the lowest priority across sectors in Ontario. This finding was of interest as during the consultation process with our stakeholders, the need for this information, so information specific to the location of injury for older adult falls, was emphasized. We know by reports such as the Public Health Agency of Canada Seniors Falls reports that 50% of hospitalizations from falls in older adults occur in the home. However, what we don't know is where in the home the fall took place, how the fall occurred, or if the rate of falls in home is different to other older adult living arrangements. Important to our process was feedback from our stakeholders to not limit the prioritization process to existing indicators. Stakeholders across sectors valued the need for indicators that may not currently exist or have data that's accessible for us to populate them. This resulted in 4 of the 8 indicators in the list not currently publicly available in Ontario, and 3 of 8 that do not have existing data sources. This may create a challenge to fully realize and evaluate the use of these indicators in practice. However, it was really important for us to consider ways to access these data and to potentially populate these indicators in future work. Finally, it was noted that the ability to interact with the data or to have the data in a type of infrastructure to allow the choosing of categories or subcategories or different strata allows practitioners the specificity that's required for their public health programming. So if we were able to get these indicators within existing data visualizations, such as Public Health Ontario's injury snapshots, it would be a really valuable piece of public health programming for fall prevention. So a prioritized specified list of indicators for fall prevention is a much needed resource for practitioners in Ontario. Referencing one set of indicators for system performance measurement can increase collaboration across sectors, potentially streamline programming, implementation, and evaluation efforts, as well as potentially better reflect the true burden of falls and fall-related injury for surveillance. The use of new indicators previously not used in practice may better reflect the work of public health units, and providing the infrastructure to support interaction with the data and indicators presented in this project can potentially reduce the duplication of efforts across sectors. So in conclusion, we used an environmental scan and modified Delphi process to establish a set of prioritized specified indicators for older adult fall prevention. The prioritized list include outcome indicators such as ED visits and hospitalizations, as well as risk-related indicators, such as the proportion of older adults with a comprehensive falls risk screening and assessment completed. The highest priority was given to the rate of ED visits and the least priority to the place where falls occur. The next step of this project includes evaluating a set of the prioritized indicators in practice in Ontario. This will be done in collaboration with practitioners from public health units in Ontario, with AFIO, continuing support and collaboration from the Ontario Fall Prevention Collaborative and our injury prevention experts. We will also try to assess the feasibility and sustainability of generating, analyzing, and reporting on the full list of indicators produced in this report. And these are just the references used in this presentation. And I thank you very much.
Great, thanks so much, Sarah. We'll pass it off to Denise, and we'll let her get started on her portion of the presentation. But thank you again, Sarah.
Great. Okay. Hello, everybody. So I'm Denise Beaton. I'm a senior policy analyst in injury prevention and healthy settings at the BC Ministry of Health. I'm a member of the BC Injury Research and Prevention Unit, and I'm also a PhD student in the School of Population and Public Health at UBC. And today I'll be speaking to you a bit about indicators, implementation, and evaluation of the BC Clinical Practice Guideline for fall risk assessment and management. So in the first two presentations in this series, I spoke about the provincial context that led to the development of this Made in BC guideline for fall prevention, risk assessment, and management for community dwelling older adults, as well as detailing the recommendations for screening and assessment. At this presentation, I'm going to be taking more of a public health lens, describing the now what after a clinical practice guideline or CPG is released. I'll discuss evidence-based best practice for implementation and evaluation of CPGs, as well as a brief overview of the implementation processes in one British Columbia regional health authority. So just as a reminder, the focus of this guideline is community-based primary care, although it may be useful in other care contexts. Hospital and facility-based care settings are outside the scope of this guideline. So when we are looking at promoting uptake and use of a CPG at the point of care delivery, this is the final translation hurdle to move scientific findings into practice. And often a lot of the focus tends to be on the development and not so much the implementation or the evaluation. When we were developing this guideline, we kept implementation and evaluation in mind, being sure to structure the format, vocabulary, and content with physicians and nurse practitioners in front of mind. It's concise in its recommendations for screening and thorough in its overview of how to conduct an effective fall and injury risk multifactorial assessment. It matches the format of other BC guidelines that it'll be used alongside, such as frailty guideline. And when it was in its final stages of development, it was reviewed by physicians and geriatricians, and older adults reviewed the patient-facing resources. And then we incorporated their feedback into the final version that's now online. The guideline was released in September of 2021, and in November, it was promoted through the National Fall Prevention Month activities that we do every year, and the Provincial Seniors Fall Prevention Awareness Week, which BC observed in the first week of November. The Ministry of Health and Finding Balance BC had social media posts promoting the guideline, and regional health authorities also promoted it through social media posts and press releases. BC Guidelines promoted it on the front page of their website as one of their most recent guidelines, where it still is. With many guidelines, this would be considered a successful launch, but there's much that can still be done. Implementation can be further enhanced through continuing medical education, practice change support, and public awareness campaigns. In February of this year, I worked with colleagues at the University of British Columbia's Division of Continuing Professional Development to create a proposal, timeline, and budget for developing an accredited continuing medical education course and workbook for the guideline. The UBC Continuing Professional Development Division of the Faculty of Medicine supports the majority of the 12,000 physicians across British Columbia with their continuing professional development needs. This division accredits hundreds of programs each year through their own accreditation office. And the goal of this partnership is to develop an accessible online module and complementary webinars that disseminate the new fall prevention guidelines to family physicians and nurse practitioners in British Columbia and support their implementation in clinical practice. We hope to begin this work as soon as possible, pending confirmation of funding. A piece that we haven't begun to investigate yet, but that will be important, is ensuring that the clinical practice guideline is also included in the curriculum for physicians and nurse practitioners currently in training. It's likely easier to learn new skills while as a student than to change ways of practice that have been solidified over potentially decades. Which brings us to practice change support. Doctors of BC, who are a partner in the development and dissemination of BC guidelines, has a practice change support program. So this would be an avenue to promote the CME accredited course and guideline featuring compensation to cover time spent learning fall risk, screening and assessment, and skilled professionals to answer questions or provide tailored support. There are 2 evaluation tools that can be used to assess patient fall risk that are promoted through the guidelines. First, the physician asks the patient the following 3 questions. Have you fallen in the past year? If so, how many times and were you injured? And do you ever feel unsteady when you stand or walk? As well as, do you worry about falling? If the patient answers yes to any of these 3 questions, it's recommended that a multifactorial fall risk assessment and fall history be carried out. The second way is for the patient to complete the staying independent checklist, which can be done in the waiting room. It can be made available in the office as a handout and distributed by other healthcare providers, such as a nurse or a medical office assistant. Depending on their score on the staying independent checklist, it will determine whether the patient is at risk of falling. And once again, recommended to have the thorough fall risk assessment and fall history. So here's a list of all of the patient-facing handouts included in the guideline. As mentioned, the guideline was promoted during Fall Prevention Month in November, mainly through Finding Balance BC, our provincial site for disseminating fall prevention education and resources to the public. However, we know that the rate of falls resulting in hospitalizations among older adults in BC remains fairly stable across the year, slightly lower in June and slightly higher in December and January, likely due to snow and ice and environmental factors. So an ongoing public awareness campaign would support the need to disseminate these resources beyond November, and organizations that serve older adults in the community could be partners. Libraries and community centers could promote the staying independent checklist. Home hardware stores could have the checklist for preventing falls at home of interest to those who are there to do renovations or maybe considering installing a grab bar in the bathroom or other support. There are many opportunities to promote fall prevention outside of November. And the first step is understanding the knowledge, attitudes, and beliefs of older adults and their caregivers regarding fall and injury prevention, and what messaging and mediums will resonate. So we're currently undertaking market research into just that. And maybe I'll speak a bit more about that at a future webinar, but I don't know. This is my 3rd webinar, so I might take a little bit of a break after this, although I do enjoy them. So everything that I just described at the provincial public health level is in its early planning stages. We delayed the implementation plan due to competing priorities, mainly of the pandemic. But I wanted to spotlight the excellent work that's been done to implement the guideline in one regional health authority in BC in particular. So this map, created by the BC Healthcare Assistance Association, shows the 5 regional health authorities in BC. As you can tell, Northern Health encompasses the entire northern half of British Columbia and serves over 300,000 people in an area of 600,000 square kilometers. They operate over 24 hospitals, several long-term care facilities, public health units, as well as additions and mental health services. And Northern Health employs about 7,000 individuals throughout the region. So Northern Health policy development and implementation is based on knowledge translation research. It assumes that developing policy and communicating it, that it exists, isn't enough. Education by itself is not enough. Strategies have to be employed to support clinicians to embed it into their daily practice and routine to make it the easy choice. Strategies have to be developed that create the conditions and address the barriers to adoption. For each major clinical area at Northern Health, there's a clinical program or a network with an executive lead and a medical co-lead, such as surgical services, critical care, mental health and addictions, elder care, perinatal care, and rehabilitative services. Fall prevention falls under the rehabilitative services clinical network. The lead's responsibility is to review externally driven priorities, such as those coming from Accreditation Canada or the Ministry of Health, and practice-driven needs across the region. They consult with the network of service providers and leaders in the health authority and select 2 to 3 priorities for improvement. Once the priorities are established, a development team is formed for each. A development team usually includes about 5 to 7 stakeholders from across the region and may include patient partners. Once the policy or clinical practice standard is developed, the group may identify what initiatives are needed to support policy implementation beyond provider education. Then implementation teams are formed. These are local teams with a champion or implementation lead. The executive lead will coordinate groups across the region, and they'll all meet intermittently with the leads as they work on implementation. So it just happened to work out that Northern Health was working on their community fall prevention strategy when they learned through the BC Fall Prevention Community of Practice that I sit on, as well as many others across BC, that this GP guideline was being developed. So they aligned their strategy with the GP guideline in terms of recommendations around screening and risk assessment tools and multifactorial assessment. It was completed in November 2021, and the group strategized around what would support implementation with their community team. And so these are the things identified. Development team members will visit sites when provincial home exercise programs are available to promote. Local site leads and champions will be identified and responsible for peer education to really have that face time, put a face to the guidelines. There's a plan to promote complementary CPG with physician groups. Regional and local leads will monitor fall rates. Regional and local leaders will do routine audit and feedback of EMR documentation. And regional and local leaders evaluate continuously these activities and the guideline on a 3 to 5 year renewal cycle. So that brings us to evaluation. Say we have implemented the CPG to increase clinician and public awareness at the provincial and regional levels. How do we actually know it's being used? We could track the number of visits and downloads to the webpage on BC guidelines, but that metric doesn't really tell us anything about how it was put into practice. Probably 100 visits in the last couple of months would be from me alone as I was refreshing my memory for this webinar. So what's most often recommended in research literature is a 3-pronged approach, including a specific billing code, surveys to physicians and nurse practitioners, and potentially to patient populations, though this didn't come up as much in the literature, and keeping track of relevant indicators. So in terms of the billing code, practitioners submit claims for services provided to the Medical Services Plan, or MSP, in BC. MSP accepts claims for medically required services that are part of MSP benefits, ensuring that the practitioner is compensated for their time and expertise, that the patient does not pay out of pocket, and that there's a record of how often a billing code is used for a specific service. Medicare in the US does have a billing code for fall risk screening and assessment. In BC, we do not. This is a key part of accurately tracking the uptake of a guideline, and something my team is very keen on exploring further. In addition to billing codes for regular services, there's also incentive fees, like bonuses, available to all of BC's eligible family physicians. These incentive fees are meant to improve patient care and many promote preventative services such as chronic disease management, complex care planning and management, and prevention, personal health risk assessment. One can imagine how a fall risk screening and assessment could be categorized under these more general incentives, especially if it's paired with a diagnostic code indicating that the patient experienced a fall previously. So Doctors of BC helped to disseminate the guideline when it was in draft for review by physicians and geriatricians. And this organization can also help facilitate surveys among the same membership regarding the uptake and use of the guideline, as well as soliciting further clinician feedback to improve it. These guidelines aren't static. They are updated every several years or sooner if there's foundational evidence that emerges. The benefits of surveys is that it's low cost and easy to repeat. But of course, limitations include that the survey results would be colored by self-reported survey and potential non-response bias. So namely, those that use the guideline would be more likely to respond than those that do not. And so we would end up having feedback from a biased sample. And finally, indicators. I'm not going to say too much about indicators because it's been covered very well by Dr. Richmond. However, they are an important way to keep track of rates of injury. So of course, while there may be a correlation between uptake of the clinical practice guidelines, it would be difficult to draw any firm conclusions that the guidelines cause a difference in rates of fall-related death or hospitalizations among community-dwelling older adults in and of itself. But I did want to draw attention to this fabulous open access manuscript published in November 2021 and developed by colleagues of mine regarding the development of policy-relevant indicators for injury prevention in British Columbia by the key decision makers. So if you'd like to read more about this process in BC, I've hyperlinked it there. So I have quite a few people to acknowledge for their support in this presentation, namely Jeanette Foreman, who is the BC CDC Northern Health Authority Lead for Injury Prevention and Safety Promotion. I reached out to her just a couple of weeks ago saying that I knew about the great work that Northern Health has been doing around implementation and uptake and asked if I would be able to spotlight it in my presentation. It was basically like I was asking for a snack and she gave me a 3-course meal. She developed the content on those Northern Health slides. She gave me speaker notes and an incredible amount of background. So thank you, Jeanette. And I'd also like to thank the Guidelines and Protocol Advisory Committee Guideline Proposal Group, as well as the working group that I was on that developed the guidelines. And of course, a big thanks to Loop for giving me this platform to talk about this guideline that is also part of implementation. And also thanks to you. Thanks for listening. If you have any follow-up questions that we aren't able to get to, or you just want to connect, my contact information is there.
Fantastic. Thanks so much, Denise. I'm just going to share my screen and it will have actually both of our presenters' contact information there for anybody who needs it. So there we go. But I just want to thank Sarah and Denise for such an excellent final webinar in this series on fall risk screening and assessment. As a reminder for everyone, you can also view the first 2 webinars in the series by joining Loop and accessing the recording and slides there. We did have a few participants submit their questions in the Q&A box, so we'll get to those in a moment. And if anyone has any additional questions that now that they've seen the entire presentation and want to enter those in, then please feel free to do so. In the meantime, I'm just going to go over a few housekeeping items. When the webinar has ended after our Q&A section, you will be redirected to Zoom and invited to participate in a short evaluation survey. So you'll click the blue button to continue on your browser and you'll be redirected to the survey. So thank you in advance for filling that out. It really helps us shape the upcoming webinars, and it also provides feedback for our presenters. And we want to provide that for them since they do such a good job, and they should hear your praises. So let's move on to the Q&A portion. I'll start with the first question, and this one is for you, Sarah. It's which were the 3 indicators without data sources, and how is this going to be addressed?
Oh, that's a great question. So the three, it's a loose three, but the two that we have no data sources for is the proportion of older adults with a, sorry, something just fell off my desk. The proportion of older adults with a comprehensive fall risk screening and assessment completed. We know that's not systematically collected in Ontario, nor is there an existing data source that we know of that collects that information. The other is the proportion of dedicated fall prevention leads. That is another indicator that we do not currently have a data source to collect that information. And then there's two that sort of fit within this box that's a bit hard to define, in the sense that, so the number of 911 calls transported v not transported. EMS has an extensive data collection system in the province of Ontario. However, we are unsure if they document the number of fall-related calls that are transported versus not transported. In addition to that, the proportion of falls by place of occurrence, we know, in certain reports, like the PHAC report I had mentioned, they use CCHS as a data source to collect that information. But as we know, CCHS, does not have, it's not representative, one, and two, it's not systematically collected for fall prevention outcome indicators or outcomes, period. And so we do know hospital administration data sometimes has the place of occurrence either at home or in other dwellings, but we do not have information that's collected, systematically collected on exactly how the fall happened in the home. So it's a little bit variable in the sense of the reliability of those specific data sources. And so those are the three.
Great, thank you. The next question is also for you, Sarah. Does your work suggest that these indicators could also be used as core outcomes set in primary studies of fall prevention interventions?
Oh, that's a great question. Initially, this work, we learned very quickly that the existing set of indicators that predominantly public health practitioners use in their work in fall prevention is ED visits, hospitalizations, and mortality due to a fall. And although these are wonderful indicators and have an incredible utility in fall prevention practice, it's not necessarily reflective of the work of public health. And so what we had aimed to do is to understand what indicators could better reflect the work of public health and potentially be used as a sort of a set of core indicators to not only build programs of public health, but also to evaluate them. And so we work very closely with the FIO, haven't in the last couple of years. However, we're hoping to pick up our work at updating the core indicators table that a lot of epidemiologists in Ontario use to do their work in fall prevention. So we're hoping to update that with additional indicators, as well as to try to pilot some of these indicators in their use in programming. So we really are hoping for them to have that specific utility, and we'll hopefully be able to see that with our next phase of this work.
Awesome, thank you. And another question for you, Sarah. In the future, what will be expected from public health departments throughout Ontario to support your research?
So we are really hoping in this next phase, which has just started as we sort of crested and are now at the end of the first month of the new fiscal, to invite public health units that are available to provide some insight on this work in the next year. So by the end of next fiscal is to have a little sample of public health units that are available for participation to basically provide consultation with us. So we would select the indicators from the prioritized list that public health practitioners deem as important for specific for their use in public health. So we have these indicators that exist that have been considered to be important for use across sectors. But the first part of our work is to identify what of those indicators would be very important for public health practice. And if it's not that set, then what set is it? We hope to be able to develop that specific for public health. And then to take a few of the indicators and actually evaluate them. What that means for public health practitioners is for them to provide us the sort of inside scoop from a public health practitioner perspective of what it means to use indicators in building a program of health, and how are indicators used to evaluate a program of health. So it would really be consultation. We would certainly take the work in populating them and setting the evaluation indicators, but we would really love their participation in the sense of consultation.
Great, thank you. I'll give you a break, Sarah. This one's for you, Denise. Is the fall prevention checklist handout at home hardware available to download off your website? And what is the process of using it? And how do you get the data back to your local public health unit?
Sure. So we haven't started sharing it out at home hardware, but the checklist that I was talking about and all of the other associated resources are available online. I just put it in the chat box. Oh, let me make that for everybody.
Oh yeah, no problem.
There we go. Yeah, so I mean, that was one of the ideas that we've been talking about in terms of a public awareness campaign, how we can actually go out into the community and get that information to older adults where they are. So in terms of giving, I mean, really, I feel like it would be similar to what we do with the Fall Prevention Awareness Month campaign. So the BC Injury Research and Prevention Unit, who run Finding Balance BC, we partner with flu clinics and mail out posters around fall prevention awareness during November, mail them out in September and October to pharmacies and GP offices. So we would keep track of how many are requested. And so that would be one way. But generally, any fall related data is monitored and surveilled by the BC Injury Research and Prevention Unit, and they have a fabulous tool, the Injury Data Online tool that's available to everybody, which tracks, you know, emergency department visits and hospitalizations and mortality, as well as other things unrelated to fall specifically. So we also have several communities of practice that are quite active. So there's the BC Injury Prevention Committee, the BC Injury Prevention Alliance, which has people outside of public health who are working in business and also have the interest as well to meet with people in public health. And then we also have the BC Fall Prevention Community of Practice, which myself and Jeanette Foreman from Northern Health are on. So we have quite a few ways to share that information with our regional and local public health partners. Thank you for your question.
Great, thanks, Denise. Well, that is all the questions that I can see in the Q&A box. I don't see any that ended up in the chat box that didn't make their way over. So I think with that, we can probably wrap up. I want to say thank you again, Denise and Sarah. It was such a fantastic way to close off this webinar series. Thank you to our other presenters in this series, including you, Denise. I agree. You definitely deserve a break after your I guess we'll call it a hat trick of webinars. So thank you again, and thank you, Sarah. It's always a pleasure to have you. And as a reminder, if you would like to access the slides and the webinar recording, you can join Loop, and the recording will be sent out to all attendees in the next couple of days. So thank you so much again, and have a wonderful rest of your day.
Thank you.
Thanks, everyone.